Disclaimer: the contents of Studio 151 podcast and the TU Communication Disorders Connection podcast do not represent the views and beliefs of the University of Tulsa and the Mary Kay Chapman Center.
Hello, welcome back to another episode of the TU Communication Disorders Connection podcast. This is your host, Alyssa Hall, and today we have two special guests joining us as we continue our discussion into the Big Nine area of cognition. Our first guest is Samantha Okroi, a first-year graduate student at the University of Tulsa, and also one of my classmates.
Hi, thanks for having me.
And our second guest is Anna Petersen, who is a speech-language pathologist based in Reno, Nevada, and also has her CBIS.
Hi, thank you so much for having me. I'm excited.
We're excited too, Anna. It's always fun when we have two guests in the studio. And I'm going to hand it right on over to Samantha to get us started with some questions.
Thanks, Alyssa. I'm looking forward to learning more. So, Anna, what do you feel is the biggest misconception about cognition?
I think there's a couple. I think that the biggest misconception about cognition coming from within our field is that cognitive intervention can't be functional. I think a lot of people fall into a trap of doing like rote things or just worksheets. I feel like cognitive therapy kind of gets a bad rep a little bit because it's so personalized. Like cognition, people with cognitive impairments present so differently from one another and from even within the same person day to day, that I kind of think this area of our field gets a bad rep. And then from external to our field, from other professionals, doctors, nurses, PTs, and OTs, I think that there's a lot of misconception about what is and isn't an appropriate referral for SLPs to do cognitive evaluation and therapy. On the one side, I definitely get referrals for patients that aren't appropriate for our cognitive services. Like, let's say that they have cognitive changes because of an infection, like a UTI. I don't disagree that their cognition is different than it was before, but it's something that needs to be medically addressed, not therapeutically addressed. And then on the other side, I definitely think that those kind of other professionals don't always understand what we can offer patients for cognition, especially lower level cognitive patients who have disordered consciousness, like Rancho 1 through like 3 or 4. And especially when those low-level cog patients have tracheostomies, because we can do cognitive intervention and we can do speaking valves, which just inherently adds so much stimulation through like sense and communication and taste and sensation through the oral motor system, that it's already a huge cognitive service to those patients. And my team definitely has to do a lot of advocacy to get in those rooms for those patients with lower level, minimally responsive kind of cognition, because other professionals don't understand that that's part of our scope of practice.
So, going off of that, what advice would you have for future clinicians who will be working in this field with cognition?
I definitely think it's helpful for SLPs working with cognitive impairments to have a good understanding of neuroanatomy. It's helpful for me in acute care, so in the hospital where patients have new strokes and new TBIs, for me to have a basic understanding of what our neurologists and our neurosurgeons are doing for their side of the intervention, because that makes a big difference to me in understanding where their brain injury was and what has happened. And sometimes, the patient gets this neurological or neurosurgical intervention, and that's what fixes their cognition. So by the time I'm doing their evaluation, they already look much better. So I think all of that is really important to understand. Similarly, I think it's helpful to have a good understanding of the Glasgow Coma Scale, the National Institute of Health Stroke Scale, and the Rancho Los Amigos scales, because those are standardized measures that other professionals will also use and will also understand. Some of our standardized and non-standardized cognitive assessments, other professionals don't use and don't use that language. And so if we want really excellent interdisciplinary collaboration, understanding what those scales that other professionals use and understand how those present, I think could be really, really helpful. When I was in school, we read a book called Where is the Mango Princess? And I think it does a really, really good job of explaining those different Rancho levels, kind of the whole continuum for severe TBI from the perspective of a patient and their caregiver, their family member. And I think that book is awesome. I also think it does a really good job of kind of introducing that in this population, you have to get used to weird. Like, this is just a population where kind of strange things will happen or they'll do strange things, and that it's a really variable population. I think that book does a really good job of showing that even one patient, you meet that patient and they have a brain injury, you've met that one person that one day, because a different person, even with a similar injury on imaging, might look completely different. And even that same person might look completely different the day before or the next day, because brain injuries and cognitive impairments is just a really variable population. And so I think that's really important to know and get used to. And I think the best way to get used to that is to have access. So if this is a population that is interesting to you, advocating for yourself to have patients in grad school with cognitive impairments, with brain injuries, either from a stroke or TBI. And if you're not getting as much access as you would want, try to shadow in those areas. So in acute care or in inpatient rehab or an LTAC or a SNF, these medical settings where patients often have brain injuries and cognitive impairments, and just get exposure to them, because it's a really, really hard population to learn about in theory because it's so variable.
You talked about some of the challenges with communicating with other professionals. What are some difficulties that you've experienced just in general with collaborating with others?
I definitely think I work at a teaching hospital, so we get a lot of residents. And I think that that is the biggest difficulty that I have with other professionals, is doctors specifically putting in orders for cognitive evaluations without really understanding what is and isn't an appropriate referral. Hepatic or metabolic encephalopathy, so cognitive changes because of a medical issue like withdrawal or an infection like a UTI, that's not really an appropriate cognitive referral, because their cognition is different due to something that needs to be medically managed. Similarly, in my setting, we don't do a lot of cognitive evaluations for people with chronic cognitive impairments, because the demand in acute care is so high. We need to see those patients whose cognitive changes are new from a stroke or a TBI or something like that. And we definitely get some referrals for patients who have chronic cognitive changes, and we have to advocate for our team and our workflow to say, this patient already has an established cognitive impairment. In acute care, it's not that they don't need services for speech, but in acute care, it's not super important, or not important, it's not super indicated. And then the big one that I think is really, really important for us to educate doctors on is we definitely get some evaluations, some orders where they really want a capacity evaluation. And cognition is a huge part of capacity, but determining whether or not a patient has the capacity to make medical decisions for ourselves is not within our scope of practice. And we get referrals where that's really what the doctors want, and that puts our license on the line. And so we have to do a lot of education to the doctors. That's not my scope of practice. I can't determine that for this patient. I can't take that away from this patient. And if I did, that would be a violation of my scope of practice. I want to put my license on the line. And so that's something that I definitely need to advocate for our field to those doctors about.
That's really interesting, kind of turning around. Apart from the difficulties, what are the good things that you've noticed about working with other professionals?
One area that I think I have learned a lot is I used to hate when I got referrals for a cognitive evaluation from the psych team, because I used to think, well, this patient has, psych needs more than they have cog needs. So psych needs to be managing that, not me. But I had a really positive interaction with one of our psych doctors, and she explained that our cognitive evaluations can help support their decision making. And if our cognitive evaluation says, we weren't able to meaningfully determine their cognition because what's going on with their psychological disorder is so severe, that helps support them and that patient receiving the psych support that they need, whether that's placement or medication or any of those things. If we can determine that their cognition, we can't even reach it because of what's going on, and that really supports our psych doctors and those colleagues in making their decisions. So that was a really positive interaction I had with one of our doctors. We've also had really cool interactions with OT and PT, OT specifically in our trauma ICU. There's a test called the JFK, Coma Recovery Scale, that is within the scope of practice of both speech and OT, because it looks at different levels of responsiveness to different areas of stimulation. And again, this is for those disordered consciousness patients, Rancher 1 through 3 or 4. And we had a meeting with OT and our team, kind of determine how we can both use this one evaluation to write goals that works on cognition in both of our scope of practice, right? Because OT, they also manage cognition, but they manage cognition really differently than we do. So how can we use the same test to look at goals differently? And that was a really meaningful meeting. And then our PT and OT colleagues have also really been awesome advocates for our team at my hospital. When they have a patient who has a tracheostomy and needs us to be in there for speaking valve and for cog, they have been really, really awesome at advocating for those orders and pushing for us to be in with those patients sooner. Again, because what I was talking about at the beginning, doctors, nurses, respiratory therapists, they may not know that we offer those disordered consciousness evaluations and treatments. They may not know what kind of non-speech benefits a speaking valve can have, but our PT and OT colleagues who do have orders for those patients have really been helpful in helping our team get in the door and work with those patients sooner.
That's really interesting. My sister is currently studying to be an occupational therapist, and I always like to hear from her about what she's learning, and we definitely learn a lot of the same things, especially when it comes to cognition, and so that's just interesting how you can see that in the field too.
It's really cool.
So moving on, how can we best support the caregivers of those who have cognitive differences?
Absolutely. It can be, especially in acute care, right? This is a new, scary thing that has happened, not just to the patient, but to their loved ones. And I think a lot of it is education. I think it can be really intimidating to have a patient who is not doing, or have a family member who is not doing the things that they did before. So having a lot of education, and I think a lot of things that patient family members think is helpful, is being there. And it's not that it's not helpful, but you walk in a room of someone with a severe TBI or an acute stroke, and they have 10 family members in a really small room. That's an area for education, talking about, hey, this patient's cognitive capacity isn't what it used to be. It's really easy to be overstimulated, and having 10 people in here talking to them, and the lights are on, and the TV is on. I feel like that's an area that families just need that education. And a really gentle way to do that is to encourage them to take care of themselves, right? Like, my hospital has a Starbucks in it. Go take a break. Go get coffee. Go for a walk. Go to the garden. You need to be taking care of yourself too, because this is a really hard, traumatic thing that also happened to you as a family member. Also in the hospital, I think an area that a lot of families need education on is restraint. If a patient has a tube feed or a tracheostomy or IVs or all of these things that are medically necessary, and they have cognitive impairments, they may not understand the purpose of those. Restraints are in place so that the patient doesn't accidentally on purpose remove those things, but that can be a really hard thing for family members to wrap their mind around, that their loved one is restrained. And so I think that's a really good area of education, kind of reframe that. It's a safety thing. We're trying to keep your loved ones safe. These are here to keep them safe, as a reminder not to pull at these things that are medically necessary for them right now. And then some areas that I think we can empower family members to be involved with their patients, their loved ones' care, is reorientation. As patients start to participate more, I think that that's a really concrete thing that families can be involved with, right? Using the whiteboard or using external guides to be like, hey, this is today's date. You are here in the hospital because this happened. And that's something that the family can be doing for them while they're in the room. Another thing that I really, really like encouraging families to do is keep ICU journals, which is like a diary or a ship log, where the family can kind of keep track of everything that patient is doing during their ICU stay. And these can be really, really empowering for family members because it's something that they can do, but can also be a really helpful therapeutic tool for patients, because typically after a severe brain injury, especially a severe brain injury that results in a patient being hospitalized is inherently disorienting, right? And so a lot of patients don't remember a lot of the things that happened right after their accident in those early days of hospitalization. And then a really hallmark thing with TBI is difficulty with new learning. So remembering the things that have happened that day that they've been telling you that day. And so having this ICU journal can be a really concrete way to say, like, hey, this is what we did today. This is what we're working on today. And then further on in the progression of their care, when they get out of the hospital, I was talking to one of my friends who works an outpatient, and she said that a lot of her job is emotion management, right? Having a cognitive impairment, not being able to do things the way you did before can be really, really frustrating. And she said that sometimes she just needs to sit there and validate that frustration. And an ICU journal can be a really helpful tool for that. Like, here we are today, and this thing, scheduling an appointment, was really, really hard for you. But 2 weeks ago when you were in the ICU, you couldn't do these things. Like, I want you to see how far you've come, because that already is a really, really big accomplishment. And having this log of those things that the family member can be keeping track of can really, really help the patient and the family stay motivated, because it lets you see those accomplishments on a day that those accomplishments maybe don't seem as important because something else is new and frustrating.
Yeah, helping and supporting caregivers. What are some good resources that you found to just educate others and even patients about these challenges?
ASHA and the CDC both have great resources. The CDC specifically has really cool handouts for patients and kids and parents about concussion, mild TBI, which is an area of our field that I definitely think is still kind of newer and determining what kind of services we should offer those patients who maybe don't have big cognitive impairments but have cognitive fatigue or have attention things or overstimulation things. So both ASHA and the CDC have really good handouts for that. If you search Rancho Los Amigos Family Guide, I love that handout. I use that handout also to help kind of determine what Rancho level I think my patients are operating at, because it has really concrete descriptions in really accessible language about each of those levels and what to expect and what you can do as the loved one. I think that's a really awesome guide. I also think the Brain Injury Association of America has really, really good resources. You can also go in and look by state. So I live in Nevada. If you go on that website, there's a map, and I click on Nevada, and it tells me what support groups are offered in my state, when those support groups are, what other resources for patients and families are accessible in that state. Or if I have a patient who is from California or was here for like a ski vacation and got injured and is going to go home, I can look up their specific state and what services are offered there. And I think that's a really, really awesome resource. That's one of my favorite websites to use.
That's awesome. Thank you. So, last question. What do you consider to be the most valuable treatment materials for working with those with cognitive challenges?
I will use the WALK, which is the Workbook of Activities for Language and Cognition. We have a stack of them. So sometimes if I just need like a paper thing or something I should read off of or they can read off of, those booklets are awesome. But I generally try to use things that are a little bit more functional or real world, which again is hard in the hospital because it's an inherently disorienting and out of your normal kind of environment. But some things that I like, sometimes after a right hemisphere stroke, patients have left neglect. And some of my favorite things to target left neglect are maps or menus. If you think about a menu, it's got multiple columns of text. And so if the one on the left is being neglected, we can talk about like, hey, you didn't order anything from this whole entree list. We can kind of redirect it that way. My hospital is also a comprehensive stroke center. So we have an awesome stroke booklet, and I will use that for cognitive aphasia therapy. I'll have them, pull the different stages in that book. There's one about follow-up appointment scheduling. There's one about a stroke support group. So using this stroke booklet that they got from the hospital, can they use the information in it to schedule an appointment or to put that support group on the calendar, things like that. I like doing medication management tasks. So we can get like a pill box, little days on it, and we can pretend to organize medication based on like a prescription label. So are you taking it in the morning? Are you taking it at night? Are you taking more than one of them? How do you organize that in that pill box? And we can use like beads to be pills because I can't just give them medication, obviously. If the patient has their phone with them, I think that's a really cool resource. Think about how many memory aids you use with them. I use the note app, I use reminders, I use my calendar, I use my timers. I don't have a cognitive impairment. I need those memory guides. And sometimes even something as obvious as that isn't obvious to patients. I'll ask them like, hey, do you use any of these things at home? And they're like, no, I just do this the way I always have. Like, okay, well now you've had a stroke. Some of these things might be harder Let's orient to your phone. Let's try and use these apps and these tools that you already have access to. Similarly, I like the visual orientation guides in the room, especially with patients who are kind of emerging into Rancho like 4, 5, 6. Just orientation is a really big part of that. So using things that are already in their hospital room to help them reorient. There's a whiteboard that should have the date, the name of the hospital, should have the name of their nurse. I can put up a sign that has that information. We can look at the clock and we can look out of the window and be like, okay, there's snow on the mountains. What season do we think it is? Or, okay, the sun's shining. Do we think it's the middle of the night? Kind of use these context clues. And I really, really like using those tools because they're immediate and they're real. That's really helpful.
All right. I think with that, we are going to wrap up our discussion on cognition. First of all, Samantha, I want to thank you for joining us and for bringing so many thoughtful questions along today.
Thank you.
And also, Anna, I want to give a big thanks to you for bringing so much insight. You were just so knowledgeable about all this stuff from being immersed in intervention for cognition.
Thank you. It was a lot of fun.
For those of you that listened along today, I want to thank you for your time, and I hope we will catch you in the next episode.
For further information or podcast ideas that you'd like to share with us, please reach out at 918-631-2504. We would be happy to chat with you. Remember, communication is not just about words. It's about understanding, empathy, and connection. Until next time, keep listening, keep learning, and keep communicating.